Hi, my name is Chrysanthi Eastman, and today I'm going to do my presentation on breastfeeding the late preterm infant. Working as a lactation consultant, I have been trained to focus on the needs and concerns of the breastfeeding mother-baby dyad in the hospital maternity unit, NICU, and outpatient setting. As a specialist, I am trained to prevent, recognize, and solve breastfeeding difficulties. Today I plan to discuss the importance of breastfeeding for an at-risk breastfeeding population and interventions that can improve breastfeeding rates for this population. In 2011, the Surgeon General released the Call to Action to Support Breastfeeding. This identified 20 key actions needed to improve and support breastfeeding. Take a look at the last sentence from this quote. The Surgeon General is emphasizing that a support structure is needed for breastfeeding mothers. The American Academy of Pediatrics recommends that infants be exclusively breastfed for the first 6 months of life, with continued breastfeeding alongside the introduction of complementary foods for at least 1 year. The Healthy People 2020 has established benchmarks for breastfeeding and monitors the progress over time. Looking at the Healthy People 2020 chart, it shows that most mothers in the United States want to breastfeed and start out doing so. However, despite the recommendation to breastfeed exclusively for about the first 6 months, only 37.7% of infants were exclusively breastfed through 3 months, and about 16.4% were exclusively breastfed through 6 months. These rates suggest that mothers may not be getting the support they need from healthcare providers, family members, and employers to meet their breastfeeding goals. There can be multiple factors that influence a woman's decision to start and continue breastfeeding. For example, this chart illustrates the differences in breastfeeding rates across various races and ethnicities. Other relevant factors include lack of knowledge about breastfeeding, unsupportive cultural and social norms, concerns about milk supply, poor family and social support, and unsupportive work and childcare environments, which can all make it difficult for many mothers to meet their breastfeeding goals and the goals set out in Healthy People 2020. I would like to highlight some of the benefits of breastfeeding for both moms and babies to illustrate how important it is to work on protecting breastfeeding, especially as I discuss how breastfeeding relates to the late preterm infant. As you look at this slide, you can see the many benefits for breastfeeding to mothers. The longer and more often you breastfeed, the greater the protection to you and your child. In addition to the known short-term maternal benefits of breastfeeding, there are long-term health outcomes that include reduced risk to chronic diseases and cancer for every year of breastfeeding. Health risks to an infant not receiving breast milk have been identified as displayed on this PowerPoint. Some statistics to think about. The risk of hospitalization for lower respiratory tract infections in the first year is reduced 72% if an infant is breastfed exclusively for about 4 months. There is a 15% to a 30% reduction in adolescent and adult obesity in breastfed versus non-breastfed infants. And the rate of sudden infant death syndrome, SIDS, is reduced over a third in breastfed babies. The benefits of breastfeeding to mom and breast milk to babe is one of the reasons I began to focus on the breastfeeding challenges facing the late preterm infants. Human milk is important for all infants, but especially among those born premature. Human milk has bioactive components that protect the preterm infant. Breast milk is much higher in the antioxidant capacity than infant formula and may help neutralize oxidative stress on these infants. In July 2005, a panel of experts recommended infants born between 34 to 36 and 7 weeks of gestation be referred to as late preterm. This was done to stress the fact that these infants are really preterm and are at risk of immaturity-related medical complications. Breastfeeding has many benefits for this vulnerable population. However, large cohort studies consistently show significantly lower rates for breastfeeding initiation duration, and exclusivity among late preterm infants. Late preterm infants account for 71% of all preterm births in the United States from 2014 to 2016. This rise was shown among births to non-Hispanic whites, non-Hispanic blacks, and Hispanic women. I will illustrate further on in this presentation how this increase in late preterm births is affecting the number of babies breastfed. The late preterm infants are often the size as full-term infants and are often taken care of with a mother in the maternity unit. This may cause healthcare professionals to not always give these at-risk infants the special attention, treatment, and screening they need. The late preterm infant has more difficulty with sleep-wake behavior and the coordination of feeding with breathing. I often hear mothers state these babies are perfect because they sleep and they don't make a fuss. Other times the mom might tell the nurse that the baby breastfed great for 30 minutes. But when going to observe a feed, the baby does some sucking bursts before falling asleep. These are common daily occurrences that I observe, and this is why the late preterm infant is sometimes referred to as the great pretenders or imposter babies. Since late preterm infants are often cared for on the maternity unit, I found the results from both a retrospective cohort study and a population-based study significant because it demonstrated that late preterm infants who were not admitted to the NICU after birth had the highest risk of rehospitalization. Why is a late preterm infant a population at risk for breastfeeding failure? I highlighted key points on this slide: feeding difficulties, excessive sleepiness, weak sucking, which can all lead to breastfeeding failure. Establishing breastfeeding in this population is frequently more problematic than term infants because of their immaturity. Studies show that late preterm infants are at greater risk of not initiating breastfeeding and/or exclusively breastfeeding at hospital discharge. One evidence-based program that can help promote and protect breastfeeding for the late preterm infant is the Baby Friendly Hospital Initiative. Some background on this Baby Friendly Initiative. It was introduced in 1991 by the World Health Organization and UNICEF as a global effort to provide better support for the breastfeeding mothers in maternity wards due to the decreasing trends and alarmingly low levels in worldwide breastfeeding rates. The Breastfeeding Hospital Initiative encourages the implementation of the 10 steps to successful breastfeeding. U.S. facilities that achieve these high standards of care are designated as baby-friendly. A systematic review and a meta-analysis on interventions to improve breastfeeding demonstrated that baby-friendly hospital support interventions delivered in the healthcare setting were the most effective, a 66% increase in improving any breastfeeding rates. I would like to focus on 2 of these 10 steps shown on this slide to help improve breastfeeding rates for the late preterm infant. One of the 10 steps to help late preterm infants and mothers is to initiate breastfeeding within 1 hour of birth. In the hospital, we call this protecting the magical hour or the golden hour after delivery. This can be especially important for stable late preterm infants. Skin-to-skin contact keeps the infant warm, prevents crying, and allows for frequent feeding, all of which help prevent hypoglycemia. Infants interact more with their mothers, are more likely to breastfeed and to breastfeed longer, and show better cardiorespiratory stability if they have early skin-to-skin contact. Clinical implications from a study demonstrated a dose-response relationship between early skin-to-skin contact and breastfeeding. Another important breastfeeding-friendly step for the late preterm infant is teaching the mother how to maintain lactation with hand expression and/or pumping. This is because most late preterm infants have weaker sucking patterns and suction pressures when compared to full-term babies. These differences make it hard for the late preterm infant to suck in a regular rhythm, which is necessary for the baby to drink enough milk. The rhythmic sucking and effective milk removal also provides stimulation for the breast to make an abundant milk supply. Fortunately, late preterm infants develop stronger sucking patterns and suction pressures as they approach their expected due dates. Until that time, hand expression and pumping is an important step to protect the maternal milk supply and provide express breast milk for these babies. The hospital I work at is working on implementing the necessary steps to be considered a baby-friendly hospital. At the upcoming skills fair, all staff will be checked off on the skin-to-skin baby-friendly skill. The staff will be trained on where to chart the skin-to-skin took place, how long, and reasons if it was not initiated. This will help us better track the implementation of this step. As you can see by the U.S. map, we have a long way to go to increase baby-friendly hospitals. One objective in the Healthy People 2020 is to increase the proportion of live births that occur in facilities that provide recommended care for lactating mothers and their babies. Another evidence-based practice that can benefit the late preterm infant is support from a breastfeeding peer counselor and/or outpatient lactation support. Late preterm infants that had a home visit or a scheduled outpatient visit within 72 hours after discharge were associated with a decreased risk of rehospitalization. To promote breastfeeding, interventions should be delivered in a combination of settings, such as healthcare, home, and community. Combinations delivered at both healthcare settings and home significantly improved any breastfeeding rates by 23%. A randomized controlled trial was completed to evaluate the effectiveness of breastfeeding peer counselors in a low-income Latina population. The results from the study indicated that peer counselors working under the supervision of a lactation consultant were effective at improving breastfeeding rates at both 1 and 3 months postpartum. A recent report discussed how providing education to enhance breastfeeding support provided by WIC peer counselors for the late preterm infant breastfeeding dyad increased the peer counselors' confidence in their ability to support this dyad. I have discussed the importance of breastfeeding for both moms and babies, the at-risk population of late preterms, and interventions that can help improve breastfeeding rates among this population. How can we track the progress? Although the breastfeeding rates are determined for all infants, the overall breastfeeding rate should increase with interventions that improve breastfeeding for the late preterm infant. Healthy People 2020 has set breastfeeding goals, and the CDC provides a yearly breastfeeding report card, which provides data on breastfeeding practices and supports in all states. With the Breastfeeding Hospital Initiative to improve skin-to-skin and to promote and protect the mother's milk supply, and follow up with peer counseling support and outpatient support, the goal would be to see an increase in 1, ever breastfeeding, 2, breastfeeding at 6 months, 3, breastfeeding at 12 months, 4, exclusively breastfeeding through 3 months, and 5, exclusively breastfeeding through 6 months. PRATS is a population-based tracking system used in Idaho, which is an annual survey of new mothers regarding maternal experiences and health behaviors surrounding pregnancy. This tracking system could possibly be used to identify breastfeeding and improvements after interventions for late preterm infants. The USDA's Food and Nutrition Service provide a yearly report of breastfeeding performance measurements based on program participation data and the number of partially and fully breastfed infants for each WIC state and local agency. With education to peer counselors regarding support for late preterm infants, I would expect the breastfeeding rates for WIC participants to rise. Healthcare professionals should strive to fully implement breastfeeding support for mothers of late preterm infants who intend to breastfeed, in particular in the hospital setting, optimizing breast milk expression and skin-to-skin care. It is important to have follow-up support in the community, such as WIC peer counselors or community outpatient lactation support, to help these mother-baby dyads reach their breastfeeding goals and receive the benefits of breastfeeding and breast milk. A quote by Dr. Ruth Peterson, Director of CDC Division of Nutrition, states, "Breastfeeding provides unmatched health benefits for babies and mothers. It is the clinical gold standard for infant feeding and nutrition. With breast milk uniquely tailored to meet the health needs of a growing baby, we must do more to create supportive and safe environments for mothers who choose to breastfeed." Thank you for listening to my presentation.